Hello everybody. Today we are going to discuss the one of the emergency condition in ICU, that is acute fatty liver of pregnancy. So acute fatty liver of pregnancy represents both medical and obstetric emergency that can cause maternal and fetal mortality if not identified early and managed promptly. The incidence is between 1 in 10,000 to 1 in 20,000 birth. AFLP typically represents in the third trimester of the pregnancy. But we should also remember that there are around 5 to 25% of cases which can present postnatal. So it's very important to know what are the risk factors for AFLP so that we can identify this population correctly. So risk factors for AFLP are multigravid state, male sex of the fetus, then coexisting diagnosis of other liver disease of the pregnancy, that is HELP and preeclampsia, then previous episodes of acute fatty liver of pregnancy. Now about pathophysiology. In pregnancy, there is physiological decrease in the oxidation of medium and long chain fatty acid, which are mainly induced by hormonal changes. So these changes leads to the increase in maternal serum level of this fatty acid. So if there is increase in this fatty acid level, then that potentially exposes the liver to the damage. So this enzyme, which is known as long-chain 3-hydroxyacyl coenzyme A dehydrogenase, which is involved in the beta oxidation of medium and long-chain fatty acid. So sometimes there is deficiency of this enzyme because of the autosomal recessive condition. So the female who develop this condition, which is acute fatty liver of pregnancy, are more likely to have heterozygous long chain hydroxyacyl coenzyme dehydrogenase deficiency. So the dysfunction in the mitochondrial fatty acid oxidation process involving deficiency of long chain hydroxydeacyl dehydrogenase, it results into the high circulating levels of these fatty acid, which are mainly 3-hydroxy myristic acid, 3-hydroxy palmitic acid, and 3-hydroxy carboxylic acid. So this excess free fatty acid that cannot be metabolized by mother infiltrate multiple organ, which lead to the hyperglycemia and hypertension. In the liver, there is widespread microvesicular fatty steatosis resulting into hepatic dysfunction. So now let's focus on the clinical feature. It usually presents between 20 to 36 weeks with the reported median gestation at presentation of 36 weeks. Interestingly, in one of the largest series, diagnosis was made in 26% of the cases postpartum. So the clinical features are variable and non-specific and individually lacking specificity. They significantly overlap with the HELP syndrome. Like there will be presence of gastrointestinal symptoms like nausea, vomiting, which are presenting in 70% of cases, followed by abdominal pain, which is present in 30 to 70% of cases. Also, the 30% of cases presents with polydipsia and fatigue. With the progression of disease, other symptoms appear which depends upon the other organ involvement. Like there will be hypoglycemia, hepatic encephalopathy, severe hypoproteinemia, ascites, gastrointestinal bleeding, and features of acute pancreatitis. Severe disease may also result in acute renal failure, ARDS, pulmonary edema, DIC, and multi-organ failure. With worsening liver dysfunction, blood ammonia level increases, which lead to the hepatic encephalopathy, which leads to the other features of hepatic encephalopathy, which include sleep disturbance, slight confusion, strong disorientation, liver flap, and coma. So the clinical course of AFLP is characterized by rapid progression to acute liver failure, which is which is also suggested by worsening jaundice, hypoglycemia, development of coagulopathy, ascites, pleural effusion, encephalopathy, acute renal failure within 1 to 2 weeks of diagnosis. Delay in delivery and referral to the tertiary unit has been shown to be reason for multi-organ failure rate of about 38.6%. After birth, clinical and lab abnormalities typically return to normal within 5 to 7 days. So there are some adverse maternal outcome which we should be worried about, like hemorrhage, which is secondary to coagulopathy. It has maximum chances of occurring, like 52%. Ascites, then the other complications are ascites, acute liver failure, acute renal failure, encephalopathy, and hepatorenal syndrome. Then the other complications are pancreatitis, multi-organ failure, diabetes insipidus, which can result from impaired hepatic degradation of placental vasopressin. Then around 60% of the female with AFLP will require admission to intensive care unit and 20% to specialist liver. So maternal mortality has improved over last few decades and it is reported to be around between 2 to 18%. Other obstetric complications are hypertension, preeclampsia, placental abruption, meconium stain amniotic fluid, and postpartum hemorrhage. There are high rates of preterm delivery. In terms of fetal and infant outcome, there is increased rate of fetal distress, asphyxia of newborn, and neonatal intensive care unit admission. Fetal and infant deaths of around 7 to 11% have been reported. Now about investigation. Investigation of those suspected to have AFLP include liver function test, full blood count, and coagulation profile and liver test. Liver biopsy is very rarely performed because of the risk of severe bleeding with a needle biopsy secondary to the severe coagulopathy, and furthermore the disease progress very rapidly, meaning awaiting the diagnosis may delay delivery. Abnormal liver function tests depend upon the severity of the disease and it include mild to moderate elevation of aminotransferase. Like ALT level increase by 1/3-fold of upper normal limit. Then there are other features are leukocytosis, severe coagulopathy, hypoglycemia, increased creatinine, and urea nitrogen. There is a role of radiological imaging like ultrasound, CT scan, and MRI, which can help in supporting diagnosis of ALS. But their role is unclear. Classical finding on imaging are echogenicity, that is brightness of the liver and fatty infiltration. CT scan have been shown to be more sensitive than ultrasound, but typical features are present only in 50% of cases. Ultrasound was able to show this in 25% of cases. The main MRI finding is increased detectable fat. For acutely ill patient, organizing MRI and CT scan may play a role, hence their role in the diagnosis remain unclear. Ultrasound may be easier to organize and could provide additional information. ABG may show the compensated metabolic acidosis. Now about diagnosis. Diagnosis of AFLP in most cases is based on the Svanesia criteria which combine clinical and lab variable. The presence of 6 or the more listed variable is considered diagnostic of AFLP. These criteria have been reported to have 100% sensitivity, 58% specificity, positive predictive value of 85%, and negative predictive value of 100%. The Swansea criteria for AFLP is 6 or more of the following in the absence of another explanation. That is vomiting, abdominal pain, polydipsia, polyuria, encephalopathy, bilirubin of more than 0.8, hypoglycemia, raised uric acid level, leukocytosis, ascites, AST, ALT, raised AST or ALT, ammonia more than raised ammonia, raised creat, which is of more than 1.7, coagulopathy, and microvesicular steatosis on liver biopsy. So, so now it's time to discuss the DDs. So the HELP is very close differential for acute fatty liver or pregnancy. Other DDs are obstetric cholestasis and preeclampsia. So how can we differentiate all these things? So remember the ascites is more common finding in AFLP, not in REST 3 condition. Then thrombocytopenia will be absent in obstetric cholestasis. Hemolysis is the feature of HELP and obstetric cholestasis. It won't be found in AFLP and preeclampsia. Then the proteinuria will be absent, will be present in almost all the condition. LDH level, yes, again it will be raised in all condition. Aminotransferases levels will be raised in all condition. Then the other feature which is with the help of which we can distinguish is serum antithrombin level, which is decreased, which is reduced by more than 65% in AFL. So and yeah, there are chance of recurrence in all these three conditions. Now let's talk about management. Like most pregnancy unique pregnancy related pathology. So for AFLP also, the definitive treatment is delivery of the fetus and placenta. So management should be multidisciplinary, which include obstetrician, anesthetist, critical care physician, and hepatologist and neurologist. So delivery should within the 7 days of onset of symptom is associated with 100% maternal survival. But when this is delayed, for example, by 2 weeks, then the survival will be dropped to 70%. So remember, like HELP, AFLP is also not an indication for cesarean section. Where rapid delivery is crucial to maternal management, this is best done by cesarean section. Again, we have to take care of the platelets when we are taking the decision to proceed with cesarean section. Then how fast the patient recover after delivery is entirely depend upon the extent of severity of AFLP and additional complication and comorbidity. In general, patient recovers within 3 to 4 days of delivery, although it may take longer for abnormal lab result to return to normal. While delivery in most cases results in rapid reversal of pathology, in some female there is a progression of the complication which result in acute liver failure with encephalopathy, DIC, and gastrointestinal bleeding. So every possible step should be taken to minimize risk of postpartum hemorrhage, including correcting coagulation deficit. There are no studies on the use of tranexamic acid prophylactically to reduce the risk of PPH, although it is effective in high-risk patients. It has been suggested that this may be considered in female to reduce the risk of significant postpartum hemorrhage without increasing the risk of thromboembolism. So apart from PPH, the intensive monitoring post-delivery is required to identify complication that could be life-threatening. So these complications are ALF with encephalopathy, acute renal failure, DIC, pancreatitis, and gastrointestinal bleeding. So expert opinion should be sought for the management of this complication, which includes the use of blood product, correction of hypoglycemia, use of mechanical ventilation for ARDS, dialysis, plasmapheresis, and if needed, we should also consider liver transplantation. So the next question is, will plasma exchange N acetylcysteine or delivery are these intervention are associated with improved maternal disease severity, or whether it is helpful in reducing perinatal mortality? So let's have a look on ESL guidelines. So what they are saying is, so delivery should be expedited once coagulopathy and remediable metabolic derangement have been treated, and decision about the mode of delivery should be made jointly by obstetrician, hepatologist, and multidisciplinary team. So it has very strong recommendation and strong consensus. Based on limited data from small case series, the use of plasma exchange post-delivery may be considered to improve maternal disease severity and decrease the time to recovery in female with acute fatty liver of pregnancy and severe hepatic impairment. There are currently insufficient data to recommend this therapy outside clinical center with expertise in plasma exchange in high dependency setting or intensive care unit. There are no existing data to support or refute the benefit of N-acetylcysteine in the management of AFL. But the benefit have been demonstrated in other causes of non-paracetamol induced liver failure, and it can be considered in female requiring admission to ICU. It has weak recommendation but strong consensus. In the subset of female with AFLP who have severe hepatic impairment, they may require transplantation. So early referral to the transplant center should be made. Again, this carries very strong recommendation and strong consensus. Thank you guys.